like to thank the organizers for giving me a chance to speak, the Diabetes Asia Study Group, and to talk about, reflect on some of pretty much carrying on the same theme, I hope, finding ways to preserve the cells, especially for type 1 diabetes. It's no longer just imagination. I think it's reality now. These are my disclosures, and hopefully in the next 15 minutes, and might go slightly above time, but I hope that would be fine. We'd be going over the prevalence of T1D and its environmental and genetic drivers, autoimmune mechanisms, and disease staging, predicting disease progression and the relevance of remnant C-peptide, and the rationale for screening and identifying who would be screened. So just before I start, I just want to in my humble opinion, I believe there are currently three hot topics for research in type 1 diabetes. One involves prevention. Second is tech, which was very nicely covered in the previous lectures. And the third is islet transplant / stem cell transplant. My idea, I focus on all three. But preliminarily today, I'd be speaking about the first part where early detection and what that entails for our population. So without further ado, I'd get started. So this is actually a slide that I always put as a tribute to my mentor, Bruce Perkins. That's Banting and Best. I'm pretty sure they were from Toronto, and I got trained in Toronto as well. And Bruce is actually Canadian, living with type 1 diabetes as well. So I think more than 100 years of insulin discovery has passed. I'm sure we should move on to more early detection and immunoprevention methods or ideas to detect this disease before it happens. Just to give you some idea about the landscape, currently at the moment, there are almost 9.2 million people. This is from the IDF Atlas 2025. Around 9.2 million people are living with type 1 diabetes globally. 1.8 million children and adolescents are living with type 1 diabetes. Of those, 30,000 children and youth will die non-diagnosed at clinical onset of T1D. And to think that this is a disease of the Scandinavian countries or in North America is very wrong, because us here in Saudi Arabia, we stand at number 9 in terms of prevalence and incidence. And we still represent Asia and the Middle East. And I think the numbers are pretty staggering. These are from the Type 1D Index Registry. We are nearly almost up to 250,000. This is a definite underrepresentation of the number. And just to give you an example, a fellow country within the Middle East, Kuwait, which is a very small population, they have 43,000 patients as well at the moment, and not to just mention the healthy years that are lost per person. So we all know type 1D is a chronic progressive disease. Despite advancements, as was previously mentioned, 70% of the people will not achieve adequate glycemic control, leading to premature mortality, cardiovascular complications, and with that, several years of life are lost. All in all, there's definitely a unmet need for therapies beyond insulin and beyond technology. In terms of survival, I think the story isn't really different. Men who are diagnosed before age 10 years tend to lose around 15 years, and women diagnosed age before 10 years also lose around 17 to 18 years of life. And I don't even want to go into details. There was because of the sake of time, I did not include that slide, but due to disparities of insulin, particularly in Asia, that number is substantially a lot higher. So some of the really great cohorts that really studied this disease are from the UK and the US. Some of them from the US is from the DASG study or the TEDdy study. What they traditionally found, now we're moving towards the more of the nutritional and the environmental factors involved in T1D. And I think this is a very controversial topic that always gets brought up. But what's been found from these big cohorts is that cow milk is actually does not increase the risk. Omega-3 are protective above age 11. The TEDdy particularly found that there is an impact of infections, probiotics, micronutrients, and overall there is an increased reactive oxygen species. What's interesting is that nutritional intake was also associated in some studies, particularly not the stuff that we're eating, but how our internal or endogenous exposure relates to this. So overall, there's already enough heterogeneity, and imagine adding nutrition to it as well. We know genetics, so I'll just break down some of the risk factors. We know genetics almost very low, 0.4%. There's a 15-fold higher in first-degree relatives with type 1. Monozygotic twins, 30 to 70%. So what's clear, or what's commonly understood, that this is a genetic disease is not entirely true, because if that was the case, then monozygotic twins will be. However, if you have patients that have parents that have type 1 DM, you would definitely see that men with type 1 have an increased around 6% risk. Women, if they're diagnosed with type 1, or sorry, if they're aged less than 25, 4%, if they're aged more than, so a higher age is somehow protective. There's a really nice paper, again, published at the EASD last year as well, which kind of eluded this specific point, that somehow there is a maternal protection in offsprings born to mothers who are already diagnosed with type 1. And if there's either parent diagnosed at the age of less than 11, that just doubles your risk. And obviously, if both parents are involved, 10 to 25%. So really, genetics doesn't really cut it, for which there are a lot of genetic risk scores. We do know that there's a particular HLA predisposition, especially the DQB1 and the DRB1. And these genetic risk scores, again, were based on European ancestry. So GRS1 first, and then the GRS2 came along. However, not very applicable to, I believe, our population or this part of the world. But what's even more interesting is that, genetic risk scores are static risk scores. You either have it or you don't. What's definitely needed is a more dynamic risk factor assessment. So is antibody progression just the sole idea? Well, I think this is, again, very interesting review paper in Lancet published last year, which showed that what would classify as static and what would be more dynamic. In terms of dynamic, you would have your genetic, clinical, individual, socioeconomic statuses. We saw there was a clear surge recently with COVID. Was that responsible? And then all these other biochemical markers that are often overlooked. For example, I would just highlight one, chromogranin A. There's a really nice paper on verapamil and new-onset type 1D and how that's been protective. What really was highlighted in that paper was that people with type 1 usually tend to have very low chromogranin A levels. And with verapamil, these levels were restored to more normal levels. And then you can obviously go into the more molecular level and see that, again, there's due to severe heterogeneity, there is still a lot of work to be done in this field, but I feel like that's picking up as well. So overall, I believe risk scores that capture a more a dynamic picture needs to be developed, especially for different population. So now moving on to the autoimmune nature and staging of T1D. Before I move any further, I think just to start off, this is from the ADAE's consensus. Again, testing autoantibodies, again, that's not even available in some of the developed countries at all centers. But I think that's what this paper highlighted, or this consensus highlighted, was that the basic need. And then I know trouble starts when you have an autoantibody negative, which could be around 10% of the population. But I think this is a very interesting pathway just to keep in mind if you're facing somebody with age less than 35 years, you're ruling out the monogenic features, etc. And then if you were to test their C-peptides, that could give you definite hint. And obviously, if age more than 35, more so treated as, obviously, if you've ruled out everything, more so treated as a type 2, and with C-peptide levels done after 3 years. So we know that there are 5 antibodies that are classically associated. But what's important is realizing that this was a paper from which kind of established across almost 10 cohorts, where they did was that they took the antibodies and made it into clusters. Which cluster was most likely to develop What two really good findings that they found was that the cluster with the IAA, the triple antibodies, these, if they were present, more likely to progress to type 1D. Similarly, initial presentation of the IAA antibody was more likely to be aggressive and to disappear sooner as well. So some of these, I think, are key factors. I think the way this field is really excelling and progressing. There is everybody knows teplizumab is approved. We just had the launch actually last week, and we're from one of the top 5 countries that actually it's been approved in, and very soon it's going to kick in. The cost might matter, but then, people will always be looking for cheaper alternatives such as verapamil and Mounjaro. I've been lucky enough to actually have a patient started on that and actually then received the teplizumab, and it's been phenomenal, like what these alternative drugs can do. And to start off all of that puzzle, I think antibodies would definitely play a role, and understanding the different clusters, not just your genetic makeup. It's a lot more your nutritional, your environmental factors, your antibody status. It's all going to play a role. So with that, I think we're all aware that there's now a new staging. However, this was initially described by Eisenbarth around 1975, where that concept of staging was put into place. So let's say you were to have a genetic risk, and then you get a trigger from some of the triggers that we did mention, whether that's an environmental trigger, whether that's COVID, viral infections, Coxsackie virus, etc. You tend to tip over to the stage 1. Your blood sugars are normal, but you have those 2 autoantibodies. And then at stage 2 comes in where your abnormal blood sugars, however, you have developed dysglycemia as well. And then obviously stage 3 is the full-on ADA diagnosis, and stage 4 would be your established. And clearly, stage 2, within 1 year is almost 75% you're likely to develop type 1 diabetes. Some meta-analysis have shown 74, but definite 5-year risk is around 75%. And what would be that dysglycemia, whether your fasting sugars are this, or your OGTT is around 140 to 199, or even 5.7 to 6.4, or more than 10% increase in the A1C. I'm sure somebody jumping from 4.5 to 5.7, it's still normal. However, it should ring an alarm that something is going on. With that, I believe what we've covered initially, I strongly believe, and this is another idea that I was discussing as well with my colleagues, that I actually gave a lecture about that, the role of technology in this group. And I feel like that's going to definitely come into play with, OGTT is probably not the best or the most ideal test to be done. So this is just a more mechanistic model where we see where exactly the autoimmunity would go in effect. And, B cell antagonism, inhibition, T cell activation, cytokine antagonist are all involved to eventually lead to the beta cell apoptosis. Having said that, TXNIP is the actual receptor where verapamil, the calcium channel blocker, works. So why is preserving C-peptides so important? Well, just before I go into those details, classically, your type 1 develops when you're left with 25% of your beta cell mass. And we've seen that with the famous DCCT trial, which I was, again, lucky enough to actually look after DCCT participants and be at the Toronto site. Lucky enough to see that certainly certain patients that had preserved C-peptide had lower A1C at year 1. Total insulin dose was lower, retinopathy progression was lower, and lower incidence of hypoglycemia. And it's not surprising that we're actually coming up with a publication soon where C-peptide, obviously, it's actually helped preserving, decreasing decay events in those that had preserved C-peptide. So, and just to top it off, this C-peptide really is outlined, especially in the islet transplant world, where patients who did receive those islet infusions eventually had better time in ranges, lower rates of complications as well. So to recap, incidence is rising pretty dramatically, around 60 to 107% by 2040. And I think it's going to take all of us in, all the countries, everybody. There is definitely a family history risk, and yes, you do tend to develop higher, but I feel there's a lot more to type 1 diabetes that rather than just genetic risk. Cardiovascular complications, the prevalence of DK is very high. And obviously the years lost. We talked about the staging. Now we're going to talk about why to screen. I know this may seem a very, like there with classical insulin disparities around most of some of the countries around why to even screen. I think it still will hold its value, as I'll show you some data where screening actually helped reduce a lot of the complications and hence economic burden. With that, I'm just gonna outline some of the things that have been studied extensively and how it's impacted the future. There's a reduced burden of daily self-management, obviously in those that are screened. There's attenuated long-term diabetes complications. Socioeconomic impact is definitely an impact. Families, caregiver impact. There's an early detection ecosystem from all the screening. Psychosocial, reduce negative, more acceptability towards your disease or owning. I think this was a point that was mentioned earlier. The fact that you can empower. I think a lot of the times we fail as physicians to empower our patients, and this kind of begins to do that. Well, like I said, DKA at diagnosis has been studied to find out long-term memory deficits, lower cognition scores, altered brain growth, a sustainable negative effect on glycemic control over time as well, linked to increased morbidity and mortality. But what's surprising is next, 60% in countries like US actually come up to the hospital with a DK event. So again, this is where I would like to again emphasize, I know there's a lot of, this definitely helps engagement with policymakers, why this is important, even where socioeconomic or economic burdens are huge. I think presenting patients and having them stay over for almost 7 days in a hospital or whatever duration that might be has actually caused increased costs on the healthcare systems. As a matter of fact, there's a really good paper on diabetes care again. Around $327 billion are spent on diabetes care in the US. So even if you were to 1/3, if you were to give it to type 1, that's still $100 billion. And I can't even imagine like how much reduction in complications this screening program could do. Similarly, again, these are some of the famous trials, the famous cohorts that have looked into this screening program, and clearly there's a substantial difference in the DK rates amongst those that have been screened early. Again, a point that's very underlooked in caring for diabetes, the impact of the burden it carries around with their healthcare givers. So yeah, this was a study done on comparing mothers who had their children screened versus those who didn't. And clearly there was a better reduced psychological distress in those that were diagnosed earlier. So the question comes in, who to screen? Well, first and second degree relatives is ideal. What really intrigues me is this middle part, celiac. How many times we have patients showing up with celiac before, or autoimmune thyroid? So this is some of the more population strategies we can use. General population, I think Italy has started it, but I think we're a little far from that. And then obviously newborn genetic testing, which was kind of looked into in Canada as well, but then that comes with its own problems. So again, we all know celiac disease, people living with Graves' disease and Hashimoto's disease do have a higher incidence of type 1D. Maybe targeting these screening populations would be of really good help. And then these are some of the scale of T1D screening programs around the world. Unfortunate, us in Asia or Middle East aren't being part of it. However, I do have good news. Actually, our institution, specifically King Faisal Specialist Hospital Riyadh, we've started a screening program, and it's going well. Lastly, I think just the classic problem of misdiagnosing. Some of these key pearls to look out for: age. Even though type 1 is a trimodal distribution, but sometimes age can help a little bit. And obviously, we talked about the autoimmunity and BMI, The family background definitely helps. Worsening control on insulin, non-insulin therapies, excuse me. And then obviously early development of comorbidities. I do work in a renal transplant center as well. So I see a lot of these type 1s, barely 25, 29s, undergoing renal transplant. So the destruction is pretty rapid. Definitely this deserves our attention. And with that, I hope I did not go over time. I hope in the previous 15 minutes, we were able to get a somewhat better understanding of the prevalence, the autoimmune mechanisms, why disease progression and remnant C-peptide matters, and what's the rationale for screening and identifying those to be screened. With that, thank you so much, and I'd be ready to take any questions.